Okay, so I was given 20 minutes to tell you what the ideal treatment would be in a relapse patient. So my first question to myself was, well, what am I going to do with the other 15 minutes? These are my disclosures over here. And so when trying to think of the ideal therapy for your relapse patient, it is helpful to remind yourself that the treatment for multiple myeloma tends to be cyclical in nature, from induction through potentially a transplant or not if you're under the care of certain physicians, maintenance, and then sort of rinse and repeat as the patients go through relapses. And of course you have to be careful about all these considerations about whether the patient is fit or frail, transplant eligible or not, whether you're going to delay the transplant, whether you're going to do 1 or 2 transplants, what agents are going to use in maintenance, in addition to all of the disease-specific factors like cytogenetic risk. And this is not a new slide, but it illustrates the point that as we go from frontline treatment to relapse refractory, naturally outcomes become more poor with shorter durations of response, more intolerance of chemotherapy, and lastly, more comorbidities that the patient suffers, whether they have developed heart trouble, hypertension, diabetes, neuropathy. And so we have lots of new drugs for multiple myeloma, as Dr. Berenson had mentioned before, mostly in the last couple of years with a lot of approvals and a lot of excitement and buzz about new drugs coming soon. And here's the list of options for relapsed myeloma from the NCCN, which is crystal clear. So evidently it's like a Chinese menu, column A and column B. So this is not terribly helpful, except for insurance denials. And so what options do we have? So talking more about label updates and options, we have data from Pollux, Castor, and the Equuleus trials right now. So the initial FDA label for daratumumab in 2015 was as monotherapy for people who've had at least 3 prior lines of therapy, including a PI and an IMiD or a double refractory. There's an updated label saying that you could use daratumumab in combination with len or dex or bortin dex for people who've received 1 prior line of therapy. And now there's a third update saying that you can use daratumumab in combination with pomalidomide and dexamethasone for people who've received at least 2 prior therapies, including lenalidomide and a proteasome inhibitor, which of course makes me do this. So one question I had was, what defines the optimal next best regimen for relapsed myeloma? Do you go for best response? Do you focus on MRD? There's been a lot of MRD talk here so far. Do you focus mostly on progression-free survival? Of course, the board answer is always overall survival. Safety, of course, quality of life is very important, and for a treatment to be effective, it has to be tolerable. And then another issue which comes up is timing. If you were to use your most active relapse drug up front, does that screw up your PFS2, for instance? Could you not go back to that in the future? So I put a little star by MRD because that does seem to be the way the field is going, and seems to be an excellent surrogate for outcomes like progression-free survival and overall survival. And again, you've seen these curves before where every log reduction in the amount of plasmacytosis seems to provide about a year more of life in this trial from Great Britain. And then in a meta-analysis of 3 separate trials, La Horta et al. Again convincingly demonstrate that the reason why some patients in CR and VGPR don't do as well as other patients in CR VGPR is because of the MRD status. And it seems like that trumps all. This is a meta-analysis, which of course is like watching sausage being made. You don't want to see how it's done, but it's good afterwards. So let's make the case for monoclonal antibody and an IMiD. And you can make this case mechanistically. Of course, the monoclonal antibodies like daratumumab, elotuzumab work through a variety of mechanisms of action illustrated over here. Oh, good, this works. So you have cytokine-dependent cytotoxicity, antibody-dependent cytotoxicity, as well as phagocytosis-dependent cytotoxicity, and also direct inhibition of a calcium enzyme on the cell membrane surface, leading to toxicity to the myeloma cell. In addition to those mechanisms of action, elotuzumab absolutely relies on the function of NK cells as effector cells by co-binding the SLAMF7 on the NK cell as well as the myeloma cell to act both as a target and as an activator. And these are results from the ELOQUENT-2 trial, which looked at elotuzumab lenalidomide dex versus lenalidomide dex, and we can see that while response rate is modestly increased, we do see a nice progression-free survival, both at 1 year, 2 year, and as well as 3 years, with approximately 12–15% of patients not progressing on the elotuzumab arm. Daratumumab, again, you've heard a lot about, again, all those same mechanisms of actions affecting multiple sites in both myeloma, perhaps the bone marrow environment, and also immune modulation. And now we stop for a mythology review. So where do these names Castor and Pollux come from? I wondered. And they come from Greek mythology. What we see here, this lady over here, her name is Lede. She's the queen of Sparta, also happens to be mother to Helen of Troy, as well as to these two guys. This is Castor and this is Pollux. If you want, this could be Pollux and this could be Castor, I don't know. Evidently, Lede was seduced by Zeus in the guise of a swan, impregnated her with Pollux, who's immortal. That same night, Lede, I guess, was very bored and also slept with her husband, who, inseminated her with Castor. And so these are two brothers, one immortal, one mortal. It's said that in the Trojan War, the mortal one, Pollux, was killed, and Castor gave up his immortality, and they both became constellations afterwards. So anyway, here's the Pollux study design. It's for relapsed refractory multiple myeloma after one prior line of therapy. The patients could not be refractory to lenalidomide in this study, and it was DRD versus RD. And what you see here is that the DRD combination is more active, both in terms of response rate and in terms of progression-free survival over here. Not a surprising result that led to that FDA approval. What was more surprising was the MRD rate seen. And there was a tripling of the MRD rate in these patients with relapsed myeloma. And if you look at MRD status, it seemed like the treatment arm didn't matter so much as the achievement of the MRD status. So whether you got Revdex or Dara Revdex, if you're MRD negative, you did about the same. Of course, a higher proportion of patients on the DRD arm became MRD negative. Also interesting in that patients who are refractory to their last line of therapy, which is a common situation we deal with, the daratumumab still provided a significant benefit and was active. This is to be contrasted with elotuzumab in your refractory patient. You can see here on this slide that if you had a patient who was not refractory to their last prior line of therapy, the elotuzumab seemed to make a big difference in terms of progression-free survival, as opposed to your refractory patient, where the curves nearly overlap over here. Another argument for the Dara-Lin combination is that if you look at T cell subsets by sequencing the T cell receptor, you can find that there is a clonality that develops with continued daratumumab treatment, which may represent a population of myeloma-specific T cells that arise. So a nice demonstration that there is an effector population that grows under the influence of daratumumab. Back to mythology. So Dara-Pom, that trial was called the Equuleus trial, and I think this was a more interesting story. So the daughter of Chiron, he's the centaur, right, was Hippie. And Hippie was seduced by the Greek god of wind, Equuleus. There's a lot of seduction back then. And she was impregnated, and she deathly feared that her father, the centaur, would come after her. She was ashamed to tell her father, so she ran off and hid in the mountains. But word was coming that Sharon was looking for her, and so she prayed to the gods to hide her from her father. And she was changed into a mare, Equuleus, and Artemis, the Greek goddess of the hunt, eventually placed her as a constellation. And the interesting part about the constellation is that she is still hiding from her father. The head of Equuleus constellation is behind Pegasus, which is next to the Centaurus constellation. The side note, Pegasus, of course, was sired by Poseidon, and Pegasus' mother was Medusa, the Gorgon. Oh, I'm sorry, one more story. Equuleus, the other story for Equuleus is that it was a present to Castor from Mercury. The name of the foal that was given to Castor was Celerus, and Celerus means swiftness or speed, and that's where we get the word celerity from. So to move on with celerity. So in this phase 1b trial, the Equuleus trial, part of the Equuleus trial, patients that were refractory myeloma, 2 prior lines of therapy, were given daratumumab and Pollux and continued until progression of disease or toxicity. Overall response rate was excellent at 60%. 6% of patients were able to get MRD negative, which is great for patients after 2 prior lines of therapy. And we can see that the median overall survival over here was around 18 months, which is again excellent and much better than that earlier slide that I showed you for expected survival in relapsed refractory multiple myeloma. So how do we choose? So this is the sort of slide that makes statisticians nuts. Comparing phase 2 and phase 3 trials all together. What we can see with the combination of an IMiD plus a PI versus ELO and an IMiD and a Dara and an IMiD, we see higher response rates for the Dara and the IMiD over here, as well as MRD rates that are significant. When we're comparing apples to apples over here for IMiD and PI versus Dara plus an IMiD, again, the Pollux data does seem to be quite compelling in terms of overall response rate, MRD status, progression-free survival. The overall survival data is not read out yet. But thank God we have a meta-analysis, which basically did the work for us. Now, I would be lying if I told you how the math worked in this. It's a Bayesian model, so I guess there's some statistical or probability involved. Essentially, in these 17 trials, they looked at hazard ratios and all sorts of other factors, and the results very much favor daratumumab and lenalidomide. So if you would answer that pre-survey question, good for you. There is a 99% chance that Dara-Len is your next best treatment. Now, with the caveat that that Pollux trial was done in Len-sensitive or Len-naive patients. So keep that in mind. So there's your answer. What's the next logical step? ¿Por qué no los dos? Why don't you add daratumumab to our other highly effective relapse refractory regimen, which is KRD? And of course, that's being explored right now in trial as well. And that's it.